All right, let's do it. We're at 2 after the hour. I'm sure we'll have more folks trickling in, but we'll get going. Thank you all so much for joining us. I'm Jessica Shortall. I lead the Safer from Harm Coalition at R Street Institute. So our goal as a coalition is to be out in the world, learning from, talking to, connecting, and elevating the voices of people and organizations working in harm reduction with the general idea that the government should not be in the business of blocking people's access to the information and tools they need to stay safe and healthy. So we are thrilled to have some wonderful panelists here today to talk about the case for expanded methadone access. It is a super rich topic that I personally could spend hours on, so we'll do our very best. We will not get to everything. We will try to do a bit of Q&A at the end, but this is just one of a, kind of ongoing conversation that we're having in multiple formats, and just really grateful to these folks for joining us. They're among the many voices talking about methadone access and explaining where we are today and what that looks like for people in the real world. So quick intros, and please jump in and correct me if I'm get any of this wrong. We have with us today David Frank at the NYU School of Global Public Health and the National Coalition to Liberate Methadone. Dr. Jordan Nahas-Vigon, I hope I got that right, Jordan at Johns Hopkins University, clinician, and Bridget Dooling, professor at The Ohio State University Moritz College of Law. And again, I'm Jessica, the Safer from Harm Coalition for R Street Institute. Thrilled to have you all. Did I miss anything on introductions there, or should we just dive right in? All right, let's do it. I think your kind of bios and your work will come out through your answers, which I think will save us some time since we have so much to go over. So can we just start real basic? What is methadone? What does it do clinically and medically? Dr. Vigon, could you give us a very brief overview of what is it and how does it work as a medicine?
Yes. So methadone is a long-acting, full agonist opioid medication. It is one of the two most effective medications that we have for the treatment of opioid use disorder, the other medication being buprenorphine. One of the great benefits of methadone is its long half-life. So generally, once patients reach a therapeutic dose, then a once daily dose can help control cravings and withdrawal symptoms for a full day. It is also a very potent pain medication. However, and this may come up later, the duration of action for pain relief or the analgesic effect is really just about 6 hours. So that is the basics, very basics.
Thank you. Okay. And so then over to David, as a person who has taken daily methadone for years, decades, is that right? Could you add some color to that? How does it work as a medicine for you and for others who take it?
Yeah, I mean, I have, I guess, maybe a sort of a controversial kind of way of looking at it, but one that may sort of appeal to this audience. And I have been on methadone for close to 20 years. I also study it. I'm a sociologist at NYU. And so methadone is presented in this very kind of medicalized idiom, this rhetoric about it treats addiction, it helps you go from an addict to recovery, and it's kind of mysterious, particularly since methadone is an opioid, and there's this idea, oh, well, heroin's an opioid and that causes addiction, and then methadone treats addiction. And I think we're right to be critical of that idea, and we're right to get like a sort of a wait a minute. It always bothered me as a patient, and I explored it as a researcher. And so I would say to kind of give the short answer, I think methadone works in a far more prosaic way that doesn't involve the mysteriousness of treating addiction. It works by giving people who are dependent on opioids access to those opioids. So when I got on methadone, my life got better very quickly. It did not get better because I became in recovery or even stopped using drugs. It got better because I was no longer dope sick every day. It got better because I didn't have to spend all of my time trying to get money and drugs and this having to get all of my opioids from this black market, which was dangerous and unregulated and inconsistent. So, I see methadone as almost like a kind of quasi-safe supply. It's not a safe supply. It's not as good as safe supply should be, but I think those discourses are important to explore. And I say it's controversial because this idea that comparing methadone to heroin or saying maybe it's swapping one drug for another or a crutch has typically been used as an attack on people on methadone and on the program itself. I don't think it has to be that way. I think it sort of shines a light on criminalization and drug policy as being this source of harm in drug users' lives. And by getting on methadone, we have found a way to circumvent criminalization and get access to the opioids that we need in a safe, legal way. And I should point out, this isn't just my own experience, but when I interview people on methadone, and once I give them a safe enough space, they kind of say the same thing. They're like, "Yeah, I just say recovery because that's the words we gotta use." But really, what it is I don't want to be dope sick. I want to be able to have a life. So yeah, I see it in this much more prosaic, less medicalized kind of a harm reduction tool, for lack of a better word.
Well, and I find it interesting that I have not heard people talk about other medications for long-term chronic conditions in the same way. Like, why are you still taking it? Why are you still on this medication? The answer is because it keeps me healthy. It allows me to work
Sure.
and be part of my family and live my life. But methadone, we seem to talk about in an entirely different way, which probably goes to a lot of what we were talking about, about the ways in which we stigmatize people who use drugs rather than seeing this as a medical condition that deserves treatment, and something that works, right, is proven to be very effective. Just so another couple minute or two from any of you, we're going to talk about the effectiveness of methadone. It's kind of the data behind it and how well it works for people with opioid use disorder. David, you're off mute. Let's hear it.
Oh, yeah, yeah. Well, I mean, just to pick up on something that you said, I do think that the reason we frame methadone in this very kind of addiction recovery kind of medicalized way is good intentions. I think people kind of have to frame it that way. There's this dichotomy, like, oh, it's got to be criminalized or medicalized, like, and those are sort of our only two choices, and they're both problematic choices. And I will admit, framing it in the healthcare way is better and more liberatory. But yeah, I think that we're kind of trapped by that dichotomy a little bit. Yeah, maybe I'll give someone else a chance.
Yeah, a bit. If if y'all could share, I mean, there's evidence that methadone is considered gold standard treatment. It's got the longest. Again, David, I take your point very much that talking about it as purely a medicalized phenomenon doesn't work for a lot of people, and so honor that. And there is a great data set showing that it is very effective in helping people.
There is. I mean, my life transformed immediately. I mean, there's no doubt with the efficacy. I mean, I was, like train spotting. I was in and out of jail. My life was pure chaos, and now I'm at NYU. I've got my PhD. None of that would have been possible without methadone. And let me be very, very clear about that. The efficacy is not in doubt. It's the sort of why is the efficacy that I was sort of talking about. But yeah, absolutely. It's got decades of evidence that shows it reduces overdoses, it reduces chaos, it reduces hep C, transmission, all absolutely. And let me be totally clear about that.
So if we can take as a baseline, as you're saying, incredibly effective, life-changing for many people, life-changing for the communities around those people. I mean, this should be what we want, when we look at opioid use disorder. We should want these kind of outcomes for people. So let's talk about how this medicine is currently regulated, because it is uniquely regulated in all of prescription medicine in the United States, right? So we'll get a little bit later to how that regulation has changed, including very recently, but big picture. So we'll go to Bridget. We've seen this largely the same regulatory framework for methadone access since the 1970s. So how was this system set up then, and why?
Yeah, I think first of all, thanks for having me. I'm really happy to be here with y'all today to talk about this. This is a really dynamic time for the policy environment surrounding methadone, and so I think it's the right time. It's been needed for a long time, but we are finally sort of seeing the type of policy energy you want to see in a space like this. So it's an exciting moment to be looking more closely at the policy surrounding this type of treatment. So in this case, I mean, so our current regulatory environment that surrounds methadone is really distinct from other kinds of treatment. I mean, even if you just think about, the notion of having to come to a clinic almost every day in order to receive your care, it's really hard to think of another type of treatment that that exposes people to that kind of day-to-day burden. Um, so how did this happen? I mean, why was it done this way? So safe to say, we don't have the system that we have because patients and practitioners got together and tried to come up with a system that would help patients the most, right? That's not how we ended up where we are. Instead, we have a system that grew very much out of the late 60s and early 70s in the time right around the so-called war on drugs, when the political ramifications of drug use were really, really, really high and really salient. And so we had a flurry of legislative activity in Congress, creating and giving new powers to federal agencies to step in and have more responsibility. There's a kitty. More responsibility in certain areas than they had had before. And so, and methadone, to some extent, got caught up in this, but it also was sort of called out separately as well. So you had the system. This was around the time when we had the idea of controlled substances come to the fore. DEA was given the authority and the responsibility to manage controlled substances. And so you saw that was that legislation in the 70s. You also saw direction to Health and Human Services Department, at the time FDA, to come up with a regulatory program for opioid treatment programs. And that really set them on a completely different course from other types of care that you might receive at your GP, your primary care, or even an inpatient facility or outpatient facility. So it really sort of it's this branching moment in the history that you can look back on and see very clearly when we started to treat methadone differently. And it's really been mostly the same since then. And so it's been a long time since then, and we have evolved our notions of what addiction is. We have evolved the set of tools that we even have to treat addiction related to opioids. And so and yet we're sort of this regulatory structure is sort of frozen in amber, right? Because it was promulgated in the early 70s. So that's the sort of the backdrop and how we got to where we are. And I know we'll spend a fair bit of time talking today about how things have evolved since then. But I do think it helps to understand the context and the environment from which these rules came, in order to understand why they're so different, why they often seem punitive, right? And they were a product of an era in which that was sort of the dominant approach to these issues.
Right. So what does it mean then? That sort of outdated language, colloquially, you hear people talk about methadone clinic, we would say OTP, right? Opioid treatment program. These are these physical locations, the only places in the country that can dispense methadone, right? And people have to go to them. We'll get in a bit to the ways in which that's changed for some people, but by and large, people have to go to these OTPs 6 days a week, right, to collect and consume their methadone in front of someone on the spot, right? And we know that we'll get into this, but that, 20% of Americans live in a county without an OTP. Many people, I talked to a doc in far northern Maine. She can see Canada out her window. And she was talking about 4 or 5 hour drive each way, 6 days a week. So the expense, all of that stuff, the time does not lend itself to access, right? And so for many people. So how does that system work in practice if we need to add anything to that? I mean, what are and in both out in the public, but also I think importantly, and I know Dr. Vigon, you have experience directly with this in carceral settings. Actually, let's talk about that for a minute. Would you mind weighing in on what this regulatory framework means for working with and supporting your patients who are in prisons and jails?
Yeah, absolutely. So this is a big issue because, as many of you know, there's a very high rate of opioid use disorder for the criminal justice involved population. So people who are in and out of prisons and jails. In the US, it's very, very, very undertreated issue and a very high risk of overdose deaths once people are released from the criminal justice system. And unfortunately, prisons and jails can't just decide to treat everybody that they want with methadone, even though I will say that starting somebody on buprenorphine or methadone while they are while they are confined to a prison or jail dramatically reduces the risk of overdose deaths once they leave. It's a small fraction of people who are actually started on these life-saving medications. So the prison or jail cannot just decide to stock methadone in their pharmacy and treat as many patients as they want. They actually have to partner or contract with an OTP to deliver that methadone, or they have to apply to become an OTP themselves, which of course requires a lot of logistics and a lot of resources. So this is not the only barrier to getting everybody who needs treatment from the criminal justice system, but it is a big barrier that we see.
And I think it's Johns Hopkins data from maybe 2022, something like 12% of correctional facilities offer any medications for opioid use disorder. So that's buprenorphine and methadone. So that number, I'm assuming, is much lower or much lower for methadone specifically. Actually, can we just take a clinical moment on if we've got buprenorphine, if doctors can prescribe it, if it's a little bit easier to work with under current regulatory structure, why do we need methadone?
Well, so from the clinical standpoint, the medications do work in slightly different ways. And certainly patients have a preference for one or the other. So some feel that one works better than the other for them. Some people have a bad reaction to one or the other. So personal preference is definitely involved a lot. And that should be the case, right? With any medication that we're prescribing, a patient should feel comfortable taking that medication and feel like they have some autonomy in the choice of it. But I will say that with the current extensive illicit fentanyl supply in the market, sometimes buprenorphine doses just don't get high enough to treat withdrawal and cravings as effectively. And there are more and more illicit substances coming into the supply. Xylazine is really big here in Baltimore and Philadelphia. And so sometimes the buprenorphine just doesn't hit all the receptors in the same way that methadone does. So it is important to have more than one option for treatment.
Mm-hmm.
Can I add on to that a little bit? Oh.
Please, David, go ahead.
Yeah, I mean, I would say yes, it is a personal choice, has a lot to do with it, but as Jordan was kind of alluding to, the methadone's more potent. It's a full agonist rather than a half agonist, and from the point of view of people taking either methadone or bupe, I meet very few people that prefer bupe. You know, everyone likes methadone, and it's because you feel it more. Like whatever that means to you, craving, high, reduced tolerance, it works more. You're like, okay, I've taken an opioid now, and I'm not getting cravings, and I'm not in withdrawal. Whereas bupe, it's like, well, maybe I kind of feel okay, but it ain't really doing the trick. And you want to feel good, like anybody wants to feel good. You know, whatever that means in terms of euphoria or whatever. I rarely meet anyone that prefers bupe. The people I meet that take bupe take it because of the access. I mean, I don't mean to totally generalize. There are people that do prefer bupe. But a lot of people take it because you don't have to go to the OTP system. And I think methadone is a more clinically effective drug because of its pharmacology.
And you're saying, I mean, everyone's different, of course, and that's true for any medication and how it makes you feel and how it lets you go about your day. But the people you talk to by and large prefer methadone because it means they can go about their day in their life without a lot of the issues that are being caused by their opioid use disorder, right? And then
Yeah, well, I mean,
how
I
that
wouldn't phrase
shows up
it
is
that way,
different.
but I mean,
Okay,
yeah,
okay.
yes. And the people that I interview too, it's not just the people I sort of talk to, the people in my research.
Mhm.
Yeah, they feel you know, it's an opioid and it feels like you've taken an opioid, whereas bupe, not so much.
And what's the difference then? I can imagine, lay folks tuning in and going, so it feels like you've taken an opioid. What's the difference between taking methadone and taking an opioid purchased on the illicit market in terms of effects on that person's ability to go to work during the day, to, care for family members, to care for themselves, to get through the day in a positive way? What's the difference there?
I mean, I would say probably, and probably everyone will disagree with me, but I'm the one that's taken both. Very little. If heroin were legalized and provided in a safe, way where you can get it consistently, legally, it would work pretty much the same as methadone. You develop tolerance. People often say like, "Oh, well, heroin is, more euphoric," and there is something to that. It is a little bit more euphoric, but you develop tolerance to all opioids, and they all sort of reach this sort of plateau where you're like, "Yeah, I kind of feel it, but I'm not high." And that happens with heroin. That happens with methadone. That happens with any opioid. So yeah, I think the difference is negligible between them, except for how they're regulated.
I will say that pharmacologically speaking, with fentanyl, so fentanyl is a very short acting, quick on, quick off in terms of the euphoric effects. And then that can subsequently lead to needing to use multiple times in a day to avoid being sick from it. Heroin, a little bit longer acting, not as high of a peak. And then methadone, much longer acting. So that's why it then controls that withdrawal symptom for that, hopefully that full day.
Thank you. Yeah. And I think it's an interesting point you make, David, that I think a lot of lay people don't know, and is something I've had to learn, is that we're not talking about, in kind of common, colloquial phrasing, being high all day, right? In either case, this is about, I'm not going to put words in your mouth. What is it about?
Well, yeah. I mean, heroin is not like alcohol. It's not like a super intoxicating kind of drug. Most people, aside from the lifestyle of being a heroin addict, which is determined by a lot of things that aren't pharmacological or biological. Yeah, I mean, I took heroin for years, and heroin, quote unquote, heroin addicts always say, the problem isn't when you have it, it's when you don't have it. Like if you have heroin and a regular safe supply, I'll go to work. When I was using a lot before it really went off the rails, this is in Portland. I mean, I was a web programmer. Every day I would stop off on the way to my job, buy my heroin, shoot up in the bathroom, and go and program websites all day. And it was no problem at all. The problem comes like when suddenly you don't have it and you're sick and all that. So yes, it's not intoxicating in the way that alcohol is, where it would really interfere with things. The interference comes from the lifestyle, which is related to drug policy.
Got it. Okay, well, let's get into accessibility, since that's so much what we're, here to talk about today is, the case. What is the case for expanded access to methadone in whatever way that looks? And there are debates about current proposals, rule changes, et cetera. Do they go far enough? Do they not? Who do they include? Who do they leave out? And I hope we can get into some of those. But before we can do that, we have to talk about, well, what is the case for expanding access out of the current regulatory structure? So I think in your work, David, so you've had folks describe the current system as quote, liquid handcuffs. So like to hear from, any of you, but what is like for folks to access methadone at an OTP 6 days a week? And how does that impact their lives and their families and their livelihoods, and their sense of autonomy and their, kind of how they live out their day and their week every week?
Yeah, sure. And please shut me up if you want other people to talk. This is a lot of the focus of my work. And it's just like what you would imagine. It's impossible to go to a methadone clinic every single day of your life. A lot of them are closed on Sundays, so you don't have to go on Sundays, although some are open on Sundays. But I mean, it's impossible. You have to go stand in a line. You don't know how long the line's going to be, so you never know how long you're going to be there. I mean, how could you manage a job that you got to be to at 8 o'clock every morning if you've got to go to this unknown amount of time? They might call your name out, and you've got to go meet with your counselor. It's completely structured in a way that prevents you from sort of stabilizing, going to school, getting a job, and then particularly like what if you got to go out of town for like a wedding or a funeral? You got to beg your clinic to either give you some extra bottles or maybe you could guest dose in a city, neither of which are good options. And this is why this is the main reason we see such low rates of uptake and retention. I talk to so many people that are like, God, I would love to be on methadone. It would absolutely transform my life. But there's no way that I could go drive an hour or 2 hours or even 30 minutes every single day and be handcuffed to that clinic. It's just not feasible. It's literally not feasible to do.
I mean, as a parent, I don't know what would I do for childcare?
Yeah,
I,
of
my
course.
husband was out of town last week with, had his car gone and my car broke down and we just had to do the most mundane things possible and everything broke down because my car wouldn't start. And so like to
Sure.
think about something as high stakes of just feeling well every day and getting
Yeah.
there, this is just a barrier to people even bothering to start, I imagine, but then also just
It's a
staying.
huge,
Yeah.
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 And you can't call and say like, "Oh, I'm running a little bit late. Can you?" I
Mm.
mean, because it's this punitive kind of carceral thing. You don't have autonomy, and you mentioned autonomy too. I mean, this makes people feel bad about themselves. They're not given the path to like, now I'm stable, now I'm autonomous, now I have a job, and it's really like, I mean, problematic in almost every way. So, I'll let other people add on to this.
And what happens if someone misses a dose? I mean, Dr. Vigon, I'm sure treated folks who have. Bridget, I'm sure you've looked into this as well. What happens when their car breaks down? They cannot, their work won't let them off. Their kid is sick. The mundane things that happen to all of us. What happens when someone misses a dose? What happens to them personally, and their health, and what happens to their, ability to continue to access that medicine after that day?
Yeah, usually from a clinical perspective, if you miss one dose, and you will alert the methadone clinic, like, you don't get kicked out but it really, if you are missing, even 2 or more days, they will often cut your dose. And then you have to sort of work your way back up, which methadone is a little bit tricky to prescribe. And so it does take some close monitoring titration to get back up to a full dose. So your dose can certainly be cut if you're missing appointments. You can be kicked out of a program for missing appointments. But then just really from that clinical standpoint, if you can't get there because of whatever, you have COVID that day, you have your car breaks down, you will go into withdrawal. You will be severely uncomfortable from that.
And that I imagine then could cause some people to seek relief elsewhere.
Absolutely.
Yeah. Yeah. And we've talked, I'll do a shameless plug when I have a second and throw it in the chat. We have a letter to the editor of the Washington Post last week talking about, we hear so much about supply. We've got to stop the supply of fentanyl into this country, but demand for those drugs is part of the equation, right? I mean, that's how supply and demand work. And if we can help people not have to take that route, that's an important part of the picture. I also just want to flag that I know you all live in this world, so not that it seems normal to you, but it's a sort of normal thing to talk about. Is there any clinical rationale? What is the clinical basis for saying you missed a dose of any medication, your insulin, your blood pressure medication, your medication for depression, whatever? What is the clinical rationale for saying you missed a dose, so now I'm gonna force you to miss more doses, or I'm going to lower your dose? What's the evidence for doing that?
So again, from a clinical standpoint, there is some basis there, and that if that tolerance, like David was talking about, tolerance builds up over time. And so if somebody is off their medication for a while, then it is very possible that tolerance decreases. And if you go back to that same higher dose, then there is a risk of oversedation or overdosing. So that risk does exist. Again, oftentimes this is done can be done in a more punitive way. But from a clinical standpoint, there is a justification for assessing how many days or doses have been missed and adjusting the medication safely based on that.
And what about kicking someone out of the program altogether for missing doses?
I would say that there is no evidence for that from a harm reduction standpoint.
Mm-hmm. That's just punishment.
Yeah, and I mean, sometimes people, yes, that it can be used as a punishment, and but there are, there are rules to a clinic that patients have to follow, and so it just may be that clinic or that time isn't right for that particular patient, but unfortunately, there's not other alternatives to it, right?
Mhm.
So it's not like they can go to their doctor and get the prescription. It's not like they can, they're, especially if they're in a rural community, they can't just go to a different clinic, right? And so there's just not a lot of access.
Yeah, got it.
And I
Okay, and
just
we
wanna
will get in, I see in the Q&A, people asking, we will get into what are the current things happening and what are the options, but I do want to just ask, before we get into that, and we're talking about what this access problem, who it affects and how. And so I wondered if you all could speak to which populations are particularly impacted by the way this system is set up. And some of it we've touched on, people with maybe, limited transportation options is a great example, but if y'all could, and we've talked about rural folks as well, we've talked about carceral settings. I've heard stories and seen, reports on people who need to go into a skilled nursing facility for a completely unrelated health issue and being told you have to choose. Either you can move into this facility by going off your methadone, or you can stay on methadone and not get the care you need for your other health issues. So there's some awful choices like that. Any other implications, any other populations we're missing here in this conversation?
Bridget, I saw you were going to say something before. You want to take this one?
I was, but not on this topic. So
Oh, well,
so-
let's hear what you were going to say, Bridget.
Oh, well, what I was going to add was just, I mean, what I find so illuminating about the conversation we just had about like what it really looks like to be somebody who is a patient receiving methadone, but also try to live their life. I mean, I think if you just think about, I think this is just a really powerful element of this issue that I think people can relate to, because if you think about, if you take anything daily, right, blood pressure medication, anti-anxiety, antidepressant meds, even like a dermatological cream, right? Just think of all the pharmaceutical substances that you might use daily or from time to time or something. And imagine if to use any of those, you had to go to a place to do it, right? That you couldn't take those meds unless you were, being sort of supervised by a healthcare professional. It just really, it's really head turning the amount of restriction. And you can say because methadone's special, you can say that it's justified, but it's really an extreme set of measures, while we allow people to take all kinds of medications at home, unsupervised, some of which can be risky too, many of which can be risky too. So I just think that's worth dwelling on, because it's part of what is so astonishing about this regulatory landscape is how truly different the delivery system is, and that and what you mentioned at the end there, that there really are not options. So it's not the case that you can just say, look, this setup is not working for me. I had a life change and I need to be more mobile, or I need to be home more, or I need to be in my community more, and I can't do, a 70-minute drive each way, or even a 30-minute drive, or even a 5-minute drive each way to make this happen every day. It's just not going to work for me. We really don't have another way for people to get this kind of medication, and that's really ponderous, because we're accustomed to being able to go to CVS, to sort of go to these alternative, and pick up a prescription ourselves and take it at home, but that really doesn't work in this space. And I think that's a really important point, and I hope a key takeaway for folks watching this webinar is that methadone really is treated exceptionally.
And connected to that, I mean, it's an interesting point because, as we said, these OTPs are often the only game in town in terms of access for a very long way. So does that impact the type of care they give, the ways in which they focus on patients versus, focus on how they, how they run their operations? It seems to me you've got one game in town, one player that folks have to go to, the sort of captive audience. Have we seen implications from that system in terms of the extent to which care is patient-centered, accessible to patients, accessible hours, the way patients are treated? What are we seeing in that space? That's for anybody, everybody.
I mean, yeah, totally. When you have no choice, the only, I mean, people that could take away your dope sickness and make you be able to have a stable life are the OTP or, of course, the black market. Yeah, they know that, and they have very little incentive because you can't, choose with your feet, and you can't walk out and just be like, oh, well, I'm just gonna. I mean, maybe you could go to another methadone clinic, although if you have the option, and many people, rural settings don't. And it's likely that even if you do have other options, they're going to be similar. So yeah, I mean, and this is why I know we're going to get to the Mota Act soon. But yeah, this is why it's so important to give people a choice, a consumer kind of choice, so that we can choose. Oh, I like the service I'm getting at this place rather than the service that I'm getting at this other place, because they know that we can't do that, and they're not. I mean, there is a lot of diversity in clinics. I should say that there's cool ones, there's not cool ones. None of them are that cool, but there is diversity. But yeah, they know that you're captive to them, and they're carceral. They hold all the cards.
Mm-hmm. Okay, I'm looking at time. There's so much more I wanted to talk about, how methadone doesn't show up in prescription drug monitoring programs, what it looks like when someone comes to the ER. Dr. Vigan, we had a long talk about that, but now we're behind. So we are going to do more on that. We'll write some blog posts. We'll do something and get into all of that. But let's talk about expanding access to methadone. So we've talked about already, I think I'll just run through this and pull from what you all have said. Goals of expanded access are making it more patient-centered, helping people set their own goals, making it accessible at all. This isn't like make it more accessible or more convenient. It's like literally make it people able to access it, full stop. Treating, opioid use disorder not as something to be punished, but as something to help people be healthy, living with, and enable more settings like carceral settings, like skilled nursing facilities, et cetera. So all of those are, matter if we care about the people with opioid use disorder, if we care about the macro picture, if we care about the, demand for fentanyl and other drugs, primarily the people. So let's talk about some of the changes lately. And Bridget, I know this is, a strong area of expertise for you. So if you could help us understand the evolution of COVID era changes, as well as what has happened with some recent rule changes, that'd be wonderful.
Yeah, this is super timely, so I appreciate the chance to talk about it. So in the pandemic, I mean, we've talked about particularly the take-home limitations and that folks have to go to the clinic every day. So that was the status quo coming into the pandemic. And pretty quickly, within the first couple of months of when it was clear that we were in a pandemic, the federal government invoked some flexibilities to make it easier for patients to take medication home with them, methadone patients. They also did a number of other regulatory changes too, but I'm going to focus on the take-home ones here today. So they basically made it so that patients didn't have to come to their clinics every single day, or at least they gave the opioid treatment programs the option to or I suppose technically they probably gave the state the option to take advantage of flexibilities like this. If the state opted in and if the OTPs opted in as well, you see what's happening here. There's a lot of choices that have to be made in order to implement these flexibilities. But at least at the federal level, the federal rules relaxed a little bit to make it so that people didn't have to come to the clinic every day. And the rationale for that was trying to promote social distancing, right? To allow people to stay home, to stay off public transit, for example, to not have to be in a healthcare setting every single day. So this gave us an opportunity to see how these flexibilities played out in practice. There was a ton of research. I mean, just dozens of studies that folks put together around this time. That was really a remarkable research effort. And the upshot of all of that is that the flexibilities worked really well for patients, worked really well for providers, and we can talk more about that if you'd like. But SAMHSA, which is the regulatory agency that oversees OTPs, DEA does as well, but SAMHSA has significant authority over these OTPs. proposed to extend these flexibilities past the pandemic. So saying, let's keep these forever, right? Basically, like we can have nice things, right? So they proposed to extend these flexibilities. And then just about 2 weeks ago, they finalized those flexibilities as well. So it is now going forward the case that the regulations support more flexibility with respect to take home requirements. You used to have, and I'm just going to read a little bit from the old take home requirements from the old rule. There was a possibility of take homes prior to the pandemic, but the criteria were pretty restrictive, and it boiled down to whether the patient was, quote, responsible enough to have take home medication. So you can see, even in that regulatory language, the sort of paternalism, the top down, we know what's best type of judgment calls that we were asking providers to make. The new criteria for take homes, there still are criteria, but there's more flexibility, and the language is not, I would argue, as problematic as the language and the language and the idea is not as problematic as they were in that 70s era regulatory language. So those changes have been made final, and other opportunities. SAMHSA took the opportunity basically to make other regulatory changes as well for OTPs. But I think I'll leave it there because that's sort of the biggest regulatory change on take homes, because I know we want to talk about the possible legislative work as well.
Yeah. And I mean, is it accurate to say these changes have been, I know, welcomed by the community, that, broad, diverse community of folks that have been making the case for expanded access? Many of those folks think they don't go far enough.
Yeah.
Is it accurate that these changes, my understanding is, leave some discretion to OTPs and to states, so the sort of implementation is not uniform across OTPs?
Yeah, that's right. And so basically, it's the federal government making it possible to do things like give expanded take homes, whereas before there was really like a much harder legal test for those programs to make. But there still has to be willingness both at the state level, at the program level, so at the OTP or sort of the methadone clinic level, and then at the prescriber level as well. So you see many, many points at which, this flexibility could be rejected. But at least the regulatory change, right, has been made to allow for some changes downstream. But the implementation really, really matters.
Yeah.
And that's very important. I just want to say, there are, as Bridget was talking, there are so many levels where they could reject it, and they do reject it. Beth Meyerson at University of Arizona did a study recently that found, I don't remember exactly what it was, but like very few clinics gave the maximum amount that they were able to. A lot of clinics gave patients no extra take homes. And, people often think, oh, we just got to change the federal regs, and we do got to change the federal regs. But these clinics have a lot of autonomy, and they're operating out of their ideological perspectives, which are, not to beat a dead horse, based on this idea of addiction. And, they're just like, no way I'm giving these addicts, these extra take homes. So yeah, we need to change the clinic system as well, because they don't often implement these things.
I have dropped in the chat what I think is that study. I'm Googling as
Oh,
fast
cool.
as you're talking. So it's
Okay,
called
thank
Nothing
you.
Really Changed: Arizona Patient Experience of Methadone and Buprenorphine.
Perfect.
Great. Okay.
And
Fantastic.
the legislation proposes that addiction physicians or addiction providers.
Yeah, so let's talk about this. Let's talk about Mota, please. It's called the Modernizing Opioid Treatment Access Act. I just want to say this is an educational session. This is not a lobbying session. I think it's great to talk about what this bill does and doesn't do without us engaging in what it, whether it should or shouldn't pass. That's where we are on today's panel, but would love to hear. Yeah, Dr. Vigon, could you talk a little bit about Mota as it's shorthanded?
Well, I can talk, yes, and Bridget probably has can fill in a lot of the details on the sort of actual legislation proposals, but it does propose this expansion for addiction providers to be able to prescribe methadone as well, which is a step in the right direction. It still doesn't expand access to everyone, right? There aren't that many of us addiction providers out there, and so it does make a step in the right direction, but it's not universal access. One thing that briefly we touched on is that currently methadone doesn't go through the pharmacy system. So if it is prescribed by a medical provider in a clinic and dispensed from a pharmacy, then that alleviates a ton of patient safety risks from the current setup that we can delve into further. But that is certainly a benefit of having a provider prescribe it and then pick it up at the pharmacy, is that more people that, it shows up in the prescription drug registration, medication lists and all that.
I know, I was blown away when you were describing to me, you might have a patient present in the ER for whatever, a broken leg, whatever it is, right? And you don't have eyes because of the current system on
Yeah.
whether that person is taking methadone. They may tell you they are, you can't confirm that necessarily, or certainly not quickly, or they may not tell you that. And so then you have some serious safety considerations for how to treat and help that patient, right?
Absolutely. We see this on a daily basis in the clinical setting, is that somebody comes in, say, to the emergency room for an acute issue, maybe even a life-threatening issue. You can't necessarily easily or quickly confirm that they're on methadone. You have to know their methadone clinic. You have to call their methadone clinic. If it's an evening, a weekend, a holiday, that may be delayed not just by hours, but actually by days. And so a patient may go into severe withdrawal. They may be tempted or actually leave the hospital, even though they have an acute life-threatening condition that needs treatment. Make it even more challenging. The patient isn't clearly thinking because they're so sick. They can't say the name of their methadone program. They're intubated. They can't breathe, right? Without the help of machines. They can't tell you what their methadone clinic is. You can't actually verify what dose they're on to give them this medication. And that severe withdrawal then may complicate their clinical situation even further. So I actually have tons more examples, but I will spare you at this time.
I feel a blog post or something together where you can kind of lay some of these out. So we'll just
Absolutely, anytime.
I'll share the Safer from Harm website link in the chat and would love for people to check back in on that. So okay, so maybe we can talk about Mota, since it is the going, we're sort of about the art of the possible. This is the bill that is in Congress right now. It has seen some motion in the Senate. It's got bipartisan support on the Senate side. So it is a heavy topic of conversation among people who care about methadone access. I wondered if we could spend a little time talking about what the stated concerns are, whether it's through Mota or not, of expanding access, allowing some or all doctors to prescribe it, allowing pharmacies to dispense methadone to patients. So, Bridget, I wonder if you could talk briefly about diversion. We hear a lot, some concerns. We hear people saying, no, we shouldn't move out of the OTP system because people will sell their methadone, right, to others or divert it to other people. So, what does the data tell us, or what have you seen about how often methadone gets diverted and why? And has the take-home scenario that you've described, COVID and moving forward, has that changed diversion meaningfully?
Yeah, thanks. So I'm just trying to pull up is my sort of shorthand definition for what diversion is, because
Yeah,
I
I
think it's a good.
absolutely botched that, so thank you.
No, you did just fine. I think what is difficult about when we talk about diversion is, first of all, it's sort of a technical term. And also, it's not a defined term, really. We don't really have established metrics for what we would watch for, right? So you might know how to do sort of a chart review and sort of check for certain kinds of healthcare outcomes, for example, but we don't really have a way to just sort of pull up an index of diversion or something. There's no sort of regular statistics on that. But what diversion means is sort of general definition would be the selling, trading, sharing, or giving away, either voluntarily or involuntarily, of a prescription to someone to whom it was not prescribed. So that's a sort of lawyer's way of saying, the meds made it to the wrong hands, right? For any number of reasons. And the reason doesn't really matter. It's just, someone was prescribed a certain substance and it ended up in someone else's hands. So that's what we mean by diversion. And so this was a question around those pandemic flexibilities, were additional take-home flexibilities going to result in a huge spike in diversion? And the reason you might worry about something like diversion with other kinds of medications would be that you might see them being used inappropriately in ways that don't comport with the reason that they were prescribed. So that is just endemic to the idea of having a controlled substance, that there's certain things that we want to keep track of more closely than others. And you can have your disagreements about what should be controlled and in what manner, but that's just kind of the framework that we're in here. Okay, so in some work that I did with some colleagues at NYU, including Noah Krasik, we did a review to take a look at, what type of evidence was generated around all kinds of factors related to the take-homes, including diversion. And the truth is that there's not a lot of studies that focus in tight on that, but we did find at least some threads of things that we put together into our paper, and I'll share the link to that after I'm done talking. But the evidence was very thin, basically, and the idea was that when even small amounts of patients were aware of somebody else giving away doses, for example, the rationales there were things like needing money, trying to help someone else out, right, who didn't have access for some reason. And we've talked about the reasons why somebody might lose access to their meds, or trying to basically save up money for other purposes. So the reasons for diversion that we saw in the record around the pandemic were, I think, consistent with reasons that we've thought about for diversion before. But the punchline is, after our literature review of evidence generated during the pandemic, it was not the case that there was sort of this, sort of groundswell of medications making it into the wrong hands. Although I'm the first to acknowledge that it's very hard to measure, in part because we don't really have an established way of tracking that. DEA cares very much about diversion, but they don't produce statistics or something that would allow us to have a notion of sort of what the trends are over time.
But so with an asterisk, because the data set is not always giving you what you would want it to. You didn't see a big boom in diversion based on take homes. Is that the fair takeaway?
Yeah, that's right. And I mean, you would hope for, sort of additional research on all these topics, but diversion is sort of always this boogeyman in the background that we worry about. And there's a lot of fear around diversion, but at least in the records and the, the studies that were available to us, from the take-home pandemic flexibilities, we didn't see a spike in diversion.
Okay. And then the other piece I wanted to talk about is counseling. So we sometimes hear folks who oppose expanding methadone outside of the OTP system say, well, at the OTP, they get this holistic picture where you get counseling until the recent SAMHSA requirements, which I see Helen Redmond's question in the Q&A here. It may not be enforceable by SAMHSA, saying you don't have to pair counseling with methadone, but is it true that an OTP still can require that the person participate in counseling to access their medication? Is that correct? Can I get a nod or a shaken head on that? Even with these recent rule changes, you may have OTPs that require people to go through counseling to get their medication. Is that accurate? Yes, I'm seeing nods. Okay. So we hear people saying, no, methadone shouldn't be expanded outside of the OTP system because then we can't make people get counseling along with their methadone. So, Dr. Vigon, David, would you speak to that a bit? Personal experience, research, clinical setting. What is the rationale for tying mandatory counseling to methadone access? And does that make sense to you?
I mean, again, there's very few things that for other diseases that we require, for somebody with diabetes, we don't require them to see a dietitian, though in some cases it would be very helpful. And so I think that the same goes for opioid use disorder. In some cases, counseling can be helpful for people, but certainly should not be a requirement of effective life-saving medication. And there are studies that show that the counseling is not required to save lives from this medication. And I will say that all OTPs are not created equally. The counseling quality, the patient to counselor ratio at some of these these programs is shocking. Hundreds of patients
Mhm.
per counselor. Hard to imagine that that is really what's making the difference.
Right. And I've heard of, 300 per patient or patients per counselor, and a very high, it's a tough job, right? Very high turnover rate, high burnout. So you're not
Mhm.
even maybe getting consistency, week to week, month to month, because it's a tough profession and tough working conditions as well. Yeah.
Plus, since the relationship is the power dynamic is so unbalanced, like counseling is a relationship that must be managed by patients. It's not like a legitimate therapeutic relationship. It's like I got to get through this so that I could get access to my dose. And yes, there is diversity. I've had decent or not decent, but I've never had therapeutic relationships with methadone counselors.
And this goes back to sort of the quasi-monopolistic role of an OTP that doesn't have a competitor nearby, right? The incentive to innovate and provide top-notch counseling, even if, what you're saying is true. With my own personal therapy, I have gone, this therapist isn't working for me at all. I need to go find somebody else. And that should be true for everyone, right? The patients, no matter why they're seeking counseling, it's not going to work if you don't have that element.
Sure.
And there is, I think some mixed evidence, we can drop them in, but to support, to your point, Dr. Vigon, that mandatory counseling, does it contribute to positive outcomes? There's some evidence that it might, others that it might have negative impact, others that it, but to your point, very succinctly put, none of that, and is a reason to block people's access to a medication that is proven to be life-saving on its own. We are running out of time rapidly. I would love if y'all would take this minute while I'm talking to drop your resources into the chat. If I get to it, I'll get the ASAM, American Society of Addiction Medicine, has a download that kind of gives an overview of Mota, and it compares it. So I'll throw that in there. And so I want to do my thank yous before people start to drop off, but I'm just going to look at the Q&A very quickly. So we've talked about Mota. Thank you, T. Stephen Jones. I'm just scrolling, mentioned Helen Redmond's comment, which is important, that SAMHSA does not have the ability to enforce its new rule changes. Carolyn Bloom asks, many OTPs profit off the carceral nature of the delivery of services. What incentive do they have to incorporate the nuances present in the Mota bill, for example? And she says, we should all be outraged at how this wonderful medication is delivered. It's outrageous. So are there incentives for OTPs to incorporate, and are you seeing them incorporate some of the compelling and rising in volume feedback from folks about the problems with the current system?
I think that there are some OTPs that do believe in harm reduction, or do recognize that this service hasn't been delivered appropriately, and I think that's an incentive for some. And I think you get some that see it as an infringement on their power, that they also don't agree with in an ideological sense. But yeah, I think it's helping to change the conversation a little bit, and that kind of moves the needle.
I am very moved to see people with lived experience and people who care for people with opioid use disorder speaking up so much. And I do think that's what's going to change the game, even if it's a little step at a time, and little steps that many, I think, have rightful comments, and rightful perspectives, or valid perspectives that, this doesn't go far enough, or that doesn't go far enough. And those are fair. We don't have time to cover all of them. Unfortunately, we've got a minute left. So now I'm talking at kind of double speed, but wanted to thank you all very much. And just for bringing so much passion to the topic, and keeping our eye on the ball, that these are individual people who deserve autonomy in their healthcare and in their lives. I have just been stunned to go down the methadone rabbit hole and see how differently we treat this life-saving medication. We talk a lot about wanting to save people's lives in the opioid crisis that we're in, and we have this tool in front of us that we are just not utilizing even fractionally to what we could. So just thank you for hanging in there and bringing so many varied perspectives. I'll note, I did see in the Q&A, and it's a very good point, Canada, the UK, there's other countries, kind of peer countries of ours, that manage this in exactly the way we're describing, prescribed by doctors, dispensed by pharmacies, and they are not seeing any of the kind of gloom and doom outcomes that we've heard in opposition to expanding access to methadone. I certainly hope that we can continue having the conversation about how we can, normalize this medication as something that people deserve autonomy and access to getting to live healthy lives. So thank you all very much. If people are still with us, I know we're a minute over, but if you got any parting thoughts, be happy to hear them. And we will get the video link, if y'all look in the chat, up, I don't know when, next couple of days, to this event. And I think it's going to spur many more conversations that we'll try to have in different formats. Any parting thoughts? Because we do still have 20 people hanging in there with us.
I would just love to express some gratitude. Thanks for the platform to talk about this and to keep the conversation going, because as much as, you know, the patient and the provider community, the public health community, and, you know, family caregivers of all of those people, you know, have been speaking up for a very long time, I actually think this is an issue with much broader appeal as well, especially once you point out, you know, how differently methadone is treated compared to other life-saving care. And I think that really people find that shocking once you put it in front of them. So thank you for giving us an opportunity to just bring that information to more people.
Thank you so much.
Thank you.
Absolutely. Yeah. Thank you.
Yeah, we appreciate you, and we'll be writing and speaking and publishing and doing more on this over at R Street and the Safer from Harm Coalition. I will throw that in the chat. Little second shameless plug for organizations active in harm reduction, or even who just work with people who, I guess that's not hyperlinked, but y'all can type it in, work with people who are, you know, disproportionately impacted by opioid use. We work across issues, sexual health, tobacco harm reduction, you name it. We'd love to hear from you. And we will be, like I said, you know, talking about this issue, which I've become very personally passionate about and matters to us a lot as an organization going forward. So thank you all for taking the time and bringing your experience and your voices and your care for people to the conversation. So thanks so much.
Thank you.
Enjoy the rest
Thank
of your
you.
day.
Yep.